Good afternoon, everyone. We'll allow a couple of minutes for everyone to get logged into the room. Thank you so much for joining us today. We're expecting a really large crowd and a lively discussion with Dr. Inder. I hope she's expecting a lively discussion. Terry, we'll try not to wear you out today.
Oh, when it comes to imaging, that's hard to do, Wendy.
All right, we'll just give everyone a couple of minutes more. We're a minute after. So we will give everyone just another minute. I know the day gets away from us sometimes, and everyone is joining from around the world. So from whatever time zone you're joining, welcome. Good evening, good afternoon, good morning. All right, why don't we go ahead and get started? As a reminder, this is being recorded and will be available for viewing on our website in just a couple of days. But first of all, let me welcome you all to a webinar. It's been a while since we've done a webinar. We gave everyone a break after COVID. I think we were all over Zoomed and over Teamed for a while. So we're very excited to come back to webinars as a way of bringing what we hope is valuable insight to the community. And I think we have the very best speaker to bring us back to these activities. So joining us today is Dr. Terri Inder, who I am very comfortable in saying most of you will know and know of her. But Terry is currently the director for the Center for Neonatal Research at Children's Hospital of Orange County in California, here in the U.S. Dr. Inder is obviously well known as a dual board certified neonatologist and neurologist whose passion is the newborn brain, from preterm, sick newborns, really everything to do with providing the very best care for brain development in the NICU. So with that, I'm going to turn it over to Dr. Inder for the first in our two-part series to help demystify a little further the use of MRI in the NICU. Terry, thank you again for joining us, and we will give the webinar to you.
Thanks so much, Wendy, and thank you all for joining today. It always feeds my soul to see that people want to learn more about how to use imaging and how to understand imaging. And I really encourage neonatologists everywhere to not be afraid of imaging. So let's talk about what we're going to cover today. We're going to cover some basic topics, and I'm going to talk a little bit more about what the images mean. And we'll come back to more of this in part 2 with more cases. And we'll look at newer ways of using MRI in part 2. But in part 1, we're going to look at how to MR an infant, what kinds of images you get off there, because I often get everybody who doesn't want to open the MRI on the radiology platform because they're like, oh, there's so many different images, it's too scary. So we're going to talk about that, and we're going to talk about how to apply that knowledge, particularly with the term and the preterm infant. So first of all, how do I image an infant? And I hope I'm talking to a group who are already convinced that you do not have to offer sedation or anesthesia. And I know this looks a little scary looking at this baby all bundled up like it's about to be, thrown out of the boat in its little life raft. But this is one of the devices that exists. And many times people are doing this without any device at all, just with good swaddling. But the key to this is really that an hour prior to any scan, the infant needs to be sort of wrapped in a blanket, sometimes the outer layer, and given some sort of head covering, either a swimmer's earplugs or some earmuffs to keep the noise level down a bit. The infant obviously has to be fitted with MR-compatible ECG leads, an oxygen saturation probe, temperature probe for us when we're doing scans where we need to monitor the temperature, and the intravenous tubing, depending on the type of scanner you're going to, may need to be changed. When you're putting the baby in the vacuum bean bag, that needs to be sort of pretty tightly placed around the baby just before you transport to the scanner. So we have been doing all of this in our unit before we go to the scanner. And why do we like doing that? Because it really reduces the chance that your baby's going to wake up and move. If your MR techs are doing all of this in the scanner room, one, they're wasting a lot of time. And two, our nurses, and particularly those that get used to wrapping and packing, as we call it, it's like a production line, your wrapping and packing, get very, very good at making sure the baby is optimally wrapped to stay nice and still while they're in the scanner. The other thing that's really important is you have to be able to feed the baby. The number of times I hear people say, well, we might need to sedate, so we have to have them NPO for a couple of hours before the scan. Well, any sensible baby is going to want to demand feed. And even the babies that are pretty neurologically affected will still become unsettled if they're hungry. And that unsettlement can be tonic posturing or anything. So you really need to be able to feed the baby at least usually 45 minutes before you're going to wrap and pack the baby so that the baby is feeling nice and filled and happy and is likely to swaddle and go to sleep. So for us, that this technique is really, really important and really successful. We've done thousands of scans with it. The real trick to it is being able to train your team that are in the unit to do it and help the parents understand that a scan, an MRI scan, involves no radiation, and that together with your radiology team and your nursing staff, you can make this successful so that you can wrap and pack your baby and deliver the little burrito to go in the MRI scanner without any fuss. And in the scanner, the baby goes, and the burrito, the scanning staff love it because you're in and out like the speed of light. And that helps to be able to reduce one of the main problems with the quality of the scan, which is motion degradation. So you have to be able to wrap and pack well and reduce the noise that might wake the baby up, particularly when we're jumping between sequences. So inserting earplugs and covering the ears and performing the noisier sequences towards the end of the scan, because the MRI scanner produces a white noise. It's like going for a ride in the car. And most parents know that when they take their baby for a ride in the car, the first part of the journey might be a bit grumpy, but then suddenly the baby seems to drift off to sleep and you actually don't want to arrive where you're going to because you've got this lovely sleeping baby. So keeping those noisy scans till the end is really helpful. Additional sort of methods can be used by the technical team, which include sort of just changing the way the scanner ramps up. Many of you may have been in an MRI scanner or listened to the noises and listened to those big sort of jerky kind of changes that go on between the sequences. And in particular, making sure that the techs go quickly between the sequences, that they don't, stop at the traffic lights for a long time, which allows the infant to kind of arouse up. And even longer duration protocols with noisier sequences can really be performed. We do everything, MRI, MRS. I had a baby this week who had MRI, MRA, MRV, MRS, the whole bundle, all done, wrapped and fed and swaddled, no problems at all. In rare situations, and they are rare, when severe motion degradation really limits your ability to get the scan, you might need to develop a plan for sedation. Or you can say, let's try and repeat once, and if that still doesn't work, then try sedation. So the fundamental principles about getting high quality imaging, and I'd really encourage you all, the imaging is only going to be as good as the quality of the imaging you get off the scanner. And the first thing, of course, is to keep your baby still. The second is that you want what we call high signal to noise. And this means that you want your technicians, and this is really led by your radiologist, who's going to be your new best friend, to be able to make sure that your field of view is appropriate. You want it to be not too big. Sometimes I'll see nearly a whole baby lying in the field of view, and I just want the brain, and somehow I've got all the way down to the abdomen. So you want the brain only to be captured. You want the right sized sections of the brain, because if they're too thick, you will miss injury. But if they're too small, then it can make it very fuzzy and difficult to get enough signal back off that baby. So you want that balance, and there's lots of good data out about how to optimize these protocols. For some babies, particularly term babies, where the baby, you really want a quick scan for concerns over hemorrhage or a large infarct, you can often do thicker sections and larger voxels. That's the box in the scanner. And you can use a rectangular field of view, because that's really going to still allow you to get this maximal signal. But whatever happens, you just want to be having somebody who's looking at the imaging quality with you while you're minimizing the time that the baby's in the scan to be able to get the question answered that you want to know. And this requires working with your radiologist and looking at the scans together. Of course, today is sponsored for this webinar by the Embrace system. This is an in-NICU system, and those are newer systems that are available now to be able to achieve many of these goals. So when the scans come off in terms of the MR protocol, this is the type of MR protocol that you are going to see. You are going to see this variety of potential scans coming off your scanner. And we're going to walk through what all these sequences are and how to think about them when you want to look at your baby's imaging. So on the top panel, you can see here a thing called T1 and T2. Now, the T is just the time that we are vibrating the brain. And when we're vibrating the brain, we send in pulses to vibrate the brain, and we're vibrating protons. And when we vibrate the protons, then we stop vibrating, we give a moment's pause, and then we allow for the resonance of those protons to come out to the head coil as a signal. And the sort of the vibrations of those after we've vibrated them is what tells us about the characteristics of the tissue that is in the brain. And so depending how we vibrate them, we get different types of characteristics back about the tissues. And that will distinguish for us, as you can see on this T1 and T2, anatomy. It'll distinguish gray matter, as we'll look at in more detail, white matter, deep gray matter, myelination, and cerebrospinal fluid nicely. So it gives us accurate detail. It shows us anatomy beautifully, and it's very, very important. Below, you can see slightly blurrier looking images. And on the left-hand side, you can see DWI and ADC. These are the two types of scans you will acquire with what we call diffusion-weighted imaging, which we're also going to look at in more detail. And that diffusion-weighted imaging is what we do to look for edema or infarction in the early phase, and in particular in any baby that we are concerned with injury. And what diffusion is doing, the reason it's blurry, is it is attempting to vibrate a whole water molecule. So whereas the T1 and T2 are vibrating just a proton, now we are vibrating a whole water molecule. We are seeing how far the water molecule moves, and then we are trying to capture when it relaxes back, that so-called vibration with relaxation. Next to that is SWI, that stands for susceptibility weighted imaging. And that is a newer type of sequence that is aimed to optimize the detection of hemorrhage or blood products. And then finally, on the very right-hand side, you see two mountain-like ranges with MRS. These are MR spectroscopy. They're not frequently used in most standard protocols, but you can see there's both a short and long echo times that are shown here, and we'll talk about those in more detail. So when you open up your scans, you're going to see various nomenclatures, but they're always going to have T1, T2, some sort of DWI or B1000 or something like that, an ADC, and an SWI. So let's start with the conventional scans, and let's start with what a T1 weighted image would look like. And this is a healthy term equivalent baby. And you can see what you will often get are 3 sets of images. And this is often acquired sometimes isotropically in just one set of slices, but then we re-slice and dice the brain, if you like. Think of the brain like a block of cheese. Obviously the top left one out to the side here This is coming through on the sagittal plane. So you can see here is the airway, here's the spinal cord, brainstem, cerebellum, and you can see the side-on view of the brain. And then below that is the coronal, which is very, very important, I find, for looking for this beautiful myelination. You can see here through the posterior limbs of the internal capsule bilaterally. And what we are looking at then on the far is the axial slices going through the cerebellum, coming up into the base of the brain and through multiple slices in the brain. And these are just representative. So each of these imaging types will usually have somewhere between 60 to up to 120 or more images per type of sequence. So you can imagine just for the T1 alone, if you have a sagittal, coronal, and axial acquisition in your library, that will be 3 lots that you would see up the top, all T1, but that may account for hundreds of images. But what's most important on the anatomy is to look at the cortical grey matter. You can see that really nice, sometimes called the ribbon. And you can see it here on this coronal, just as though you were in kindergarten again and you're putting your felt tip pen all around the outside of the brain. That is the cortical ribbon, and you're going to trace that around, whether you're doing that on the coronal or you're doing it here on the axial. You're going to follow that all the way around the brain and see if there's any areas that are missing or any areas that are not got the same bright normal signal characteristics that look different. Then beneath the cortical grey matter, of course, is the unmyelinated, non-insulated axons, the unmyelinated white matter, which is the predominant white matter of the immature brain. And you can see here that it's got this kind of light grey characteristics. And you're looking essentially for scarring often in that area. And you can see it all the way here through on the axial too. And then the deep grey matter, which are actually seen in some ways better on the axial. You can see them beautifully as these 2 kidney-shaped structures here on the axial. And you can see even the outline of the lentiform and the thalamus. And often you'll be able to see more easily on the coronal, these posterior limbs of the internal capsule that are bright white because they are carrying myelination within them. So myelination within the T1 will show up as this bright white. It's the first myelination signal that's seen, and we'll compare that very shortly in the immature brain. And you can sometimes see it coming all the way up here towards the cortex where there's some subcortical myelination going on. T1 is really good at detecting macromolecules, so it's good at showing you scarring. Now, this is a comparison of an infant that did have injury, and these are the T1 and the T2, T1 above T2, over 31 days. And the reason we wanted to show you these images was the evolution of the injury as seen by the deposition of the scarring tissue. And you can see on this T1, it's pretty impossible to see anything's abnormal on day 1. That looks pretty normal. And on day 2, also pretty normal. By day 9, maybe I'm starting to be suspicious that there's some abnormal scarring in here. But by day 31, very apparent, right? You can see these 2 areas of very high signal in both the thalamus and the lentiform. On the T2, it's a little more difficult to see, right? It's there, you can see it standing out, but not as prominently as you can on the T1. And this is definitely the case for all types of scarring like this on following brain injury. So here is a comparison now with T2 weighted imaging. And I have to admit, so on the left here, I've got our T1 axials, and on the right now, these are T2s across the middle of the screen, and then again, comparisons with some T1s out on the very right. And the reason I've done this is just so that you can see the difference in the signal characteristics, right? Because the vibrations are different and the resonances are different. Now, on the T1, CSF is black, cortical grey matter is white, and unmyelinated white matter is that pale grey. And you can see on the T2, CSF is bright. So if anybody puts a picture up and you're not sure if it's T1 or T2, always just look at the CSF. And if the CSF is bright, that means it's T2, too bright, T2. And so you're then, the T2 to me is always it's really the foundation for looking at anatomy. When you first open your first imaging set, I always encourage people to open the T2 axial imaging and to scan all the way through it, even if you know you're looking for injury. Because the first thing you want to see is, does this baby have normal brain anatomy that you can see? So we can see here on this particular T2, here's a normal cerebellum. We can see the eyes now coming up with nice cortical folding that I can see. I can see two hemispheres. I can see what looks like pretty much normal brain stem, normal hemispheric asymmetry coming over here. I can see normal basal ganglia. The ventricles are visible. They don't look dilated. They don't look slit-like. And then coming up, I can see. So this looks like essentially a pretty normal brain. There's one area out here at the very top that I'm not able to follow the cortical ribbon all the way around. So is this completely normal or not? I would want to explore that area more closely by looking at other slices or other types of imaging. Like if this was the equivalent T1, did this show me the same abnormality or not? Did it reassure me that actually the cortex is intact? And this may have been what we call partial voluming, where some of the CSF got stuck there rather than it being cortex. So whenever you do see abnormalities on T1 or T2, it's helpful to look at the friend. If you see it on the T2, look at the T1. If you see it on the T1, look at the T2. But always start with your T2 to do this anatomy scan. Like, how does my anatomy look? Before I look at anything else, does this look like it was a normally formed brain to start with? And as I say, if you see an abnormality, then say, oh, I wonder what that is. I'm going to look at the diffusion. I'm going to look at the SWI. I'm going to look at my T1 to really be sure whether there is any true abnormality or not. T2 is good for detection of edema. And you can see here this comparison. This is a 4-day-old term infant with severe HIE, and this is a typical healthy brain. And you can see here the cortical ribbon we've been talking about, this nice dark ribbon that you're going to follow all the way around to see normal anatomy. And you can see on this brain, you can't do that. You might be able to sort of try to do it at the front, but as you come to the back, you completely lose all of that. And instead, what you're seeing are these black, like worm-like structures that you don't see here as easily. And this is because when you've got this much edema, the blood vessels within the brain kind of pop out. They kind of stand out, and you can see them in different areas here, right? These little worms, which aren't as visible on here because they're kind of buried in the cortical gray matter. But here you can see that they're not, and they're standing out because the background brain is so edematous that we've lost the typical cortical ribbon. We know, and here is a beautiful review that I would recommend to you, looking at some of the methodological changes and some of the newer types of sequences that are available. But these things change dramatically with age. And so what I am teaching you around predominantly is the healthy term-born brain. These are images that are taken at about a month of age. So now you can see that myelination, not just in the posterior limb, but coming back in the optic radiation as well. But you can see how much myelination changes in the first year of life. By 8 months now, you can see on the T1, this infant's brain is almost fully myelinated now with the type of characteristics that an adult or a pediatric neuroradiologist is often used to looking for compared to our little babies' brains that are predominantly unmyelinated white matter. And you can see here the premature brain, this very smooth, unfolded cortex with a very immature white matter that's extremely watery, and you can't see the visible presence of any myelination, right? So just in 9 weeks, you've seen this, or 13 weeks here, this dramatic change in brain development. The other thing that's important to know is that T1 and T2 can help you with timing of hemorrhage. And we look at the differences between the T1 and the T2 to try and tell us when the hemorrhaging might have occurred. And if it's very fresh, just a few days, we'll usually see the signal where we have what we call low T2. So you'll see it on the T2, but you won't see much on the T1. As it gets towards a week after the age, then you'll start to see bright blood, like here on T1. And chronically, you'll then see that disappear again and just the presence of the low T2. And we'll see some examples of that. So when you look at the partnership between T1 and T2, we can look at how old a hemorrhage may be, which can be helpful sometimes, particularly for babies who have got hemorrhages when you're trying to time when the hemorrhage may have happened. But one of the things that really improves the detection of hemorrhage is the susceptibility weighted imaging. So this is a baby who had a cerebellar hemorrhage, and you can see the T2 signal here, which is low, and you can see the T1 signal being bright. But look how much easier it is to see it on the SWI. The SWI, we call this a bloom, the way that it blooms the hemorrhagic signal out. This isn't exactly how big the hemorrhage is. The hemorrhage is, as you can see, probably a bit smaller, but just the way the vibrations occur, it draws your attention to it. So if a radiologist was busy and they flicked through the T1 and they didn't see this, certainly looking at the SWI would draw their attention to the fact that there's probably a hemorrhage there, and they'd go back and look carefully at the T1 and T2 to confirm that. And you can see we don't really see much on the diffusion coefficient on this. Diffusion imaging is really important to talk about because most people get very confused. Some people call it confusion imaging because there's so many different sequences that you see. We acquire diffusion imaging as a form of T2 imaging, and you often won't see this EPT2 that's thrown up, but it's basically different information that's coming off a rapid T2 sequence that we're running against different characteristics, but it's using similar types of features. So when we first get our first DWI, our raw scan, sometimes you'll see it as DWI, sometimes you'll see it as B1000. It's a combination of the movement of water and some of the characteristics of the T2. And so it reflects edema, and it reflects a failure of the cell to be able to handle the water in a way that may indicate the cell has died. So we are often looking for it as a marker of early ischemia. What you'll be looking for on the DWI is bright areas, because the bright areas are showing you the area where water movement is restricted. To be able to extract any what we call T2 shine through, which is the effect of the T2 imaging on the diffusion measures, we then apply some special filters that generate what we call the apparent diffusion coefficient. And this is a purer way of being able to try and select purely the movement of the water molecule, the apparent diffusion coefficient of the water itself, taking away any of the characteristics of the T2. And on this, now you can see the reverse is true, right? CSF was black. In other words, free water movement here was black. Free water movement here, looking at the CSF always, you can see free water movement here is bright. So now I'm looking if water movement is restricted, so-called, because the brain is injured, then I should be seeing it being the opposite of what the CSF is. It should be black. If it's a DWI and CSF movement is black, I should be looking for bright. So diffusion is really trying to measure the movement of the water molecule, and it's usually measured in multiple directions. Originally, it was only measured in 3 directions, but now we measure it sometimes up to 40 directions. But anyway, what we're doing is trying to estimate the size of this ellipsoid of the water movement. And what we're doing is estimating how much the water is moving in any of these directions we're measuring, and we estimate then the size. And that size of that ball is given a value, and that's what we call the apparent diffusion coefficient. Depending on how small or how big the ball is, tells you about the average, or the ADC, the average diffusion movement. Now, this changes with brain maturation, as we'll look at, and it changes with injury. We can also look at whether there's any preferred direction that the water likes to move in, and this is what is known as anisotropy. And this is really related to the shape of that water movement. So if I'm stuck in a fiber tract and I'm lying between two axons, I'm not going to be able to move side to side. I can only move up or down. Then I'm going to have a very strong preferred direction for my water movement. And my strong preferred direction is going to show me that my anisotropy movement, my water movement in one direction, is very high. And that's what will be seen here. And this is very sensitive to the organization of the fiber tracts in the white matter and to myelination, because myelination will produce enhancing of that organization. And we can track these. We can look at it and say, oh, if I'm moving this way, then I can follow those box to box to box, or if I'm moving this way, and I can form fiber tracts. And this is what we do with so-called tractography. When you're starting to acquire diffusion sequences, you want to work with your radiologist to really understand how you can get the best imaging. And diffusion is very sensitive to distortion. Sometimes you'll see brains stretched in weird ways, or you'll see fallout of the signal at the front and the back of the brain. You want to know that the B value that you're obtaining is optimal for the immature brain. And we often talk about B1000 because that's often a value that we use as an optimal brain value for newborn brains, but it's not a value that people are used to for pediatrics and adults. And so you want to make sure that your radiologist has optimized your scanner for newborns. You want to talk about how many directions, and you want to talk about what size box they are taking the diffusion in. Again, motion is critical to get good diffusion sequences, and you really want to try and minimize the amount of motion during these sequences because they are very motion sensitive. So this is what an immature brain can look like on these sequences. On the left, you've got the apparent diffusion coefficient, remember, because the diffusion has got bright here in the CSF, and you can see that it can freely move, and then this is an immature cortex. But if we look at anisotropy, you can already see the corpus callosum, you can see the fiber tract for the posterior and the anterior limbs. And we can color those and show different colors for the directions the fibers are moving across the corpus callosum, back to front, either along the optic radiation or in and out of the brain, as in the corticospinal tract. This is what happens with maturation using that diffusion. You can see that overall, the diffusion looks darker now because it's become less watery as the brain has matured. The diffusion coefficient overall is reduced. You can see these fiber tracts are standing out still, but there's some extra ones now with the external capsule, and you can see the strength of those tracts still present. Now, I do want to make the point right up front that please be careful that not everything that is bright on diffusion or low on ADC is always injury. Especially if you've got an infant who's got a lot of seizures going on, they can have seizure edema. That does not mean it's ischemia, which is one of the reasons, and my group are familiar with this teaching, that when I see just diffusion restriction, if I don't have a spectroscopy or something else early to support what the actual injury is, I usually like to repeat the scan a week later and see what the actual injury is, because often the diffusion will overestimate the size of the injury, and it's important to define that. We have all been stung or had times when we have thought that diffusion predicted a worse picture than what actually was present. And that's why looking at the infant and looking at the exam and looking at the EEG and looking at other markers is very important to do alongside imaging. But here is an example of an infant who had an MRI at 12 hours of life with APGARs of 5, 5, and 5, who was having seizures at occipital area. And you can see here that the restriction that was seen was very prominent here in the DWI and on the apparent diffusion coefficient. Nothing much seen on the T2, but maybe a little edema because you've lost the cortical ribbon here. And here is the child at 5 months of life who has no apparent injury in that area. And indeed, we felt this was related to seizure-genic edema because status was occurring in this region during that time. And it can be hard, right? Measuring diffusion is often something a radiologist is looking at, and here is a whole bundle of different babies, right? So starting over here, this is T2 ADC diffusion weighted imaging. Baby 1, I think no one would look at those 3 images and say there was anything going on there. Baby 2, I don't think they would also look and say there was anything. And baby 3, the same. Now, when I get over here, oh, what about this frontal cortex here? Is that abnormal on the DWI? I'm not sure. Maybe a little bit here, restricted on the ADC. When I come down here, what about these thalami here? These look restricted bilaterally, right? But it's like, oh, how dark is too dark? And then I don't think anyone would miss the lower image. But I'm just trying to contextualize for you that this is not easy. And one of the ways you can do this more rigorously is to actually measure the apparent diffusion coefficient over the region and put a region of interest over there and actually quantify that on your imaging. And you can look at other regions of the brain that are unaffected and see how they compare. We also know that diffusion is time sensitive, and when you acquire your scan is critically important. We've collected this data, as did WashU, looking at babies who had acute injury. And these were babies who did not receive hypothermia, had an acute insult. And you can see imaging in the first 24 hours, you might not see very much. But somewhere between day 2 and day 4, you will see the maximum restriction in babies who did not receive therapeutic hypothermia. But if you wait out to 7 days, you may have lost the diffusion signal completely. They will have so-called pseudo-normalized. Now, in the era of hypothermia, we repeated this. And again, that first 24 hours is a little dicey to see anything consistent. But between day 2 and 4, and particularly around day 4 and 5, you'll still see, after the hypothermia treatment, the restriction. But then after that, it does start to pseudo-normalize, but much, much more slowly than it did before the hypothermia era. But really, if you want to have your best chance of seeing the injury, you want to get as close to day 4 as you can. So hence why we try and take them straight off the hypothermia blanket and down to the MRI as soon as possible. And we don't wait a number of days. If you're going to wait, please wait for as long as possible, because these diffusion changes are really going to start to pseudo-normalize out around the 7-day period, apart from if you've got secondary Wallerian changes. And your T2 and your T1 changes are going to start to become visible really only after 7 days. So ideally, I like to wait till at least 10 days after birth or 7 days after I've rewarmed to be able to re-image to see the established T1 and T2 changes. And this is just one example. So here's an arterial ischemic stroke. You can see on the diffusion weighted image, this marked brightness with the marked restriction. And I don't think anybody would miss this on the imaging. And you can see the swelling, the nice loss of the cortical ribbon on the T2 and the swelling here on the T1. And just some prominence of a little hemorrhage on the SWI. Now, 9 days of life, you can see this infant now has nothing very visible on the DWI or the diffusion coefficient. You can see now the sort of the loss of the cortical ribbon as you're starting to dissolve the cortex on the T2. And you can see this cortical highlighting as we call it, on the T1 here, out in the same area of the region. And you can see the loss of the blood vessels out here on the SWI as this area of infarction now is starting to disappear. But even still, I mean, when you look at the original area of the restriction of the diffusion, you might say that there was a bit of edema that extended maybe just a little bit marginally more than what you are now seeing established on the T1 and T2. There are lots of different patterns of brain injury that you are going to want to look for, and here are a series of diffusion-weighted images from a beautiful article that was published in 2021. And you can see here the types of patterns we're looking for: the basal ganglia pattern, the typical deep nuclear grey matter, the watershed with the anterior and the posterior, anterior and posterior watershed, punctate white matter lesions, global severe injury, more of the deep nuclear plus brainstem, focal cerebellar injury, perinatal stroke, as we just saw, or other types of parenchymal lesions, all beautifully visualized with MR. We can also show with the diffusion what we're looking at in terms of development. And as we've said, these things change with time, and you do need to have some grasp of what is typical. Finally, spectroscopy is additionally helpful. It's not always done in most centres now, because it is something where you need somebody who is dedicated to wanting to acquire it with high quality, because the worst thing you want is poor quality spectroscopy. And that requires somebody who's dedicated to the sequence development and to the post-acquisition analysis. But if you can get it, you will get a lot of additional chemical information, including being able to look for things like your N-acetyl aspartate, which is a marker of neuronal integrity, and lactate. And on your very long echo times or your very short echo times, that's going to be an upright doublet around 1.1 parts per million. So let's look at a couple of cases. We were going to stop for some questions, but I think we'll do a couple of cases and then stop for some questions maybe in about 5 or 10 minutes, if that's all right. So this is a first case, an infant that was born at 39 weeks by a stat cesarean section due to decreased fetal movements. This mother was 39 and had negative prenatal history. Here are the APGARs. And there's your umbilical arterial gas, 6.8 with a base deficit of 17. Passive cooling was started and the baby was transferred to a level 3 NICU. The baby got conventional ventilation and nitric oxide, had 72 hours. The EEG was always very reassuring with a normal background and no seizures, but the baby did stay for some period of time due to the severity of the respiratory disease. This was the AEEG during the period, and you can see that here is this beautiful normal cyclicity that's seen with normal amplitude. And this was the imaging that was done on day 4 of life. And you can see on the T2, this is slightly immature brain, but very nice cortical ribbon that's traced all the way around, very nice white matter with no apparent abnormalities, and the basal ganglia seen bilaterally. You can see the posterior limbs of the internal capsule present bilaterally, and nothing that is bright on the diffusion weighted imaging. Remember, we're looking for something opposite of CSF, nothing that's bright, nothing that's dark on the ADC. We're looking for the opposite of the CSF. So this was regarded as an unremarkable MRI with no abnormalities detected. And how good is MRI for therefore reassuring this family that everything's going to be okay? If you look at the sensitivity and specificity, positive predictive value, negative predictive value in this setting of outcome, whether you are cooled or not cooled, it's extraordinarily high. And in the presence of cooling, you can see here, which is what we're often dealing with now, the negative predictive value is above 90%, positive predictive value of 76%, and the sensitivity and specificity both high. The comparison I often draw is how good is a chest x-ray. If we are getting a chest x-ray because we want to diagnose either pneumonia or a pleural effusion, in adults for pneumonia, it's very high, but for a pleural effusion, it's actually not that great. And yet we regard it as a gold standard without a blink. and MRI clearly exceeds that in this setting diagnostically. The way I think about it is a negative MRI, particularly on day 4 of life, when you don't know when the insult really happened, you've got to be a little bit cautious. It's very encouraging. And most of these children are going to go on to have completely typical outcomes. But occasionally there'll still be the odd child who really may have been an HIE mimicker, may have had something else going on, like this slightly immature looking cortex. And so 25% on follow-up, 20% on follow-up have been shown to have some sort of mild developmental issues, but they don't have anything moderate or severe. So you can be very reassuring, I believe, to the families. And obviously, as I've already emphasized, EEG and clinical exam add useful information. And of course, in our state and Massachusetts and other states, they will always get followed anyway if they've received hypothermia treatment, even when the MRI is reassuring. In contrast, here's a 40-week infant who was born via vaginal delivery to a prima gravida. In maternal history, as you can note, and there was some category 2 fetal tracings, corium neonitis, and the infant came out with APGARs of 3, 1, and 5. And here is the cord gas, not so different from our last one. However, this baby had no spontaneous movements, was hypotonic, with very poor neurological exam and a poor EEG. And early MRI was obtained on day 3 just because of concerns. And here is the T2. So looking at the T2, as you can see, you know, you can trace around this cortical ribbon. Everything really looks pretty reassuring. And same on the T1, you can see the extra axial blood out there, but nothing within the brain substance. But then go to the diffusion weighted imaging, and what you can now see this above is a typical normal diffusion weighted image. And sometimes these images are almost mistaken because you look over it and you're like, oh, it all looks the same, so it must be okay. But actually, of course, this is a profoundly abnormal elevated global ischemic injury. And you can see this when we also look on the restriction on the diffusion. This baby did have severe HIE, of course, and the family wished to provide comfort cares. The placenta, which is very important, showed multiple infarcts in nearly half of the placenta. And there was extensive injury in the brain on neuropathology. I wanted to show another example of a similar baby I have had here in the last few months. And this is a baby, again, that had a placental abruption at home and came in, again, had a pH of 6.8 minus 22 and received hypothermia for 3 days. This is the imaging on day 5, right at the start of day 5. And you can see this global abnormality in the diffusion-weighted imaging and this restriction across the diffusion, which it just looks almost like it's uniform and must be okay. You can see, because we're now at day 5, the loss of the cortical ribbon here on the T2 weighted imaging. And just to show you, this baby, the family had a lot of difficulty with decision making through the early phase. The infant eventually did pass peacefully, but we were able to reacquire imaging a month after the early imaging. And this is just to show you the extent of encephaloclastic, severe, profound loss of brain tissue that these early diffusion changes translate to in the same infant a month later. And you can see now just the cystic evolution of the complete dissolution of the brain. So in undertaking any of these types of imaging, it's really important that you know that whether it's acquiring the imaging, whether it's getting the imaging information, looking at the imaging, it's a collaboration. You want to know and talk with the family right up front why you're doing an MRI and why your team believes an MRI is helpful. And that includes verbal and, to me, written information. It's the same for educating a family about the cooling process. I mean, it's the consistency of the information. Your NICU team involves a team, right? And so everyone in the team should know why you want to do an MRI. That includes the nursing staff and everybody, particularly the therapy staff that's involved in the care of this baby. Neurology should be involved early in the care of these infants, and particularly around the consensus to call, but also for the MRI. If the baby was transferred, you're obviously going to have updated the referring provider on what you found, the OB team on what you found. They're often forgotten. I think it's really important right from early on that you have a good relationship with radiology, and particularly with neuroradiology. They need to understand why you need these MRIs at the time you need them, why you're going to want to look at the sequences with them, why you're going to try and improve everything all the time, and why you're just going to keep trying to push forward. And then the placenta is the other key to the kingdom. And we've been slow to embrace the opportunity of every baby that needs resuscitation and comes over to us should also have their other half, if you like, their placenta sent for analysis. And finally, obviously, the MRI becomes critical in the developmental follow-up clinic, particularly if you're looking at other potential factors. So here's our placenta. This is just one of many articles looking at the common nature of abnormalities that we see in the placentas. And it's so helpful to the families to be able to explain why something may have gone wrong. Finally, I'm just going to touch very quickly on prognosis because it's so important. You can go back and review the various patterns of injury that we looked at earlier. I can tell you that when you image these kids out over time, it can be useful. This is an infant who actually had a very severe early neonatal course and was imaged early in our aspect scanner, but this is the frontal watershed injury only that she had, despite being profoundly encephalopathic and looking like she, we were considering redirection. And then this was us following her injury over many weeks as part of a research protocol. And you can see that really out by 3 months, she's really got minimal stigmata of this initial injury, and that was associated with an extremely good prognosis for her. Again, the parasagittal type of injury that you can see here as it was displayed in that infant, you can see it now posteriorly in this baby on the early diffusion weighted imaging. That's not apparent by day 10, but now apparent on the T2 by day 10. And that kind of watershed type of brain injury is often hard to pick up in the neonatal period. There's pretty subtle neurological signs apart from seizures, but these children are at risk for a loss of IQ points, and it seems to be around 15 IQ points on follow-up. And you can see here that change in their IQ points is shown by Stephen Miller's beautiful work. However, that's nothing compared to those that have the more profound deep nuclear grey matter injury. This is mild deep nuclear grey matter injury, and you can see that little abnormality there. This is moderate, occurring both in the lentiform and the thalamus bilaterally, and this is severe. And what we are often looking at is the presence of the myelination in the posterior limb of the internal capsule to predict the presence or absence of cerebral palsy. You can see it's normally present here. It's impaired here. It's hard to see it. Maybe it's there, maybe it's not. I don't think it definitely is. And here it's absent. So instead of being bright white, like you see here, now you see it's gray or black. And this is, again, the prediction of this nice normal posterior limb or its absence. And that's important because you can classify those patterns of injury, and as has been beautifully described by Mary Rutherford and Francis Cowan's group, the risks of injury and bad outcomes relate to the severity of that basal ganglia involvement. Cerebral palsy, still a 10 to 15% risk, even in the mild kids, just with that single focal area. And if the plic is normal, they will walk normally. If it's a little bit impaired, they might be late, but they can still have some chance of impairment across these domains. But as the type of injury goes up, so does the risk, particularly the risk of cerebral palsy. If it's equivocal or abnormal, now up at 75%. feeding difficulties, speech and language difficulties, and developmental impairment, with a third of those children having a DQ less than 70. And when you get to severe basal ganglia injury, it's almost uniformly associated with severe spastic quadriparesis with uniform multiple disabilities. And these are the children who are very profoundly affected. So based on that, we agree with the guidelines that were placed out by the Newborn Brain Society about neuroimaging and about the importance of doing this imaging and doing it in this window between day 2 and 5, and then considering repeating it at 10 to 14 days, particularly if there's any discrepancy between the early imaging and the clinical conditions, or the findings require follow-up. And I'm going to pause there because I think we're going to come back to the preterm and other things in part 2. And now I'll open it up for questions. I hope that demystified at least some of the aspects and made people feel a little bit more comfortable. But I know this is a work in progress, and you're going to have to go back to your babies and your scans and start opening them up and looking at them, and even spending some time with your neuroradiologists, really understanding. But it's not hard. It's not hard, and it's so helpful. And then you can walk families through the scans and show the scans to the families and say, this is what we see, this is what we think it means, and we'd love to, to be able to have you feeling comfortable and confident to be able to do that. So I feel very privileged to be here with you all today, and I'd love to take any questions that you may have.
Terri, thank you. Thank you so much. That was, I think, a real good foundation for everyone to start. And I will remind everyone, as you're putting your questions into the Q&A or the chat feature, whichever you're comfortable with, I will remind everyone that you will be receiving a link to the recording of this presentation so that you can slow it down, as Terri suggested, maybe with your images of your own babies, and referring back to some of the great foundational instruction that Terri has provided. So with that, I will acknowledge that Zoom and I are not in a good place in our relationship right now, and I can't access the Q&A panel. So, Em, if you could maybe, oh wait, it's there now. Thank you. So Terri, I don't know if you can see the questions, but the first question is, can you comment on pseudonormalization of the MRI and HIE?
Yes, thank you so much for that question. And I hope I showed that a little bit with those graphs that show in an infant who may not have received hypothermia treatment, we know pseudonormalization is pretty prominent after about day 5 after the insult. Of course, there's always that question of when did the insult happen? And so sometimes it can be helpful in a baby who presents atypically without that typical resuscitation at birth to get that imaging a little earlier to know when your injury may have occurred. But otherwise, you're left with cooling and then imaging around day 4, and then trying to understand. But if you get your imaging on day 4, you shouldn't yet have pseudonormalized. If the baby looks bad and the images don't show you anything, then think, this doesn't make sense. Could this have happened in utero a day or 2 before the baby was born, and I'm in this naked window before T1, T2 are showing me the abnormality, and what after the diffusion may have pseudonormalized? And so just keep looking at the baby, the EEG, the MRI together as a package. And then you can always consider whether repeating the imaging, looking now, and the real meat in the sandwich is the T1 and T2 in terms of what they are telling you is established injury.
Thank you. And I think the follow-up question, I think you touched on that. How many MRIs does one need for babies with HIE to look for evolution of the brain injury? I think you captured.
Yeah, I mean, I think optimally, we know that about 20, and published recently, about 25% of these babies change, and they can change both ways. Because you can be in that pseudonormalization, you can see changes on a follow-up MRI that weren't visible at day 4. Likewise, you can see stuff on day 4 that looks restricted on diffusion, and you might tell the family that you think there's something abnormal there, but actually when you re-image them, it's gone away. And I had one of those babies this last week that did exactly that. And the family are always happy to see that. But I think that optimally, if you have abnormalities on the first scan, I usually like to repeat the scan to really define where the abnormalities have left visible, demonstrable, established injury on the T1 and T2.
All right, thank you, Terri. And a request for slides, Terri. And we haven't talked about that, but we can talk about that after
Very happy to share
Okay.
anything. I can put them into a PDF because they're kind of big, but
Exactly.
I can put them
Okay.
into a PDF if it's easier to download them or Dropbox them, or if people want them as they come. There's nothing that I wouldn't be prepared to share and help, particularly as centers are looking to discuss these things with their radiologists. And the most important relationships you can work with is that with your radiology team and your MRI technologists, because the MRI techs are like the key to the kingdom. They control the scanners, not the radiologists. The MR technologists control the scanners. And so making friends with them is really, really helpful. And then having representatives from neurology and representatives from your nursing staff. If you can get a team like that together, you are in great shape.
Thank you, Terri, for making your slides available. So we will get a link out to those for everyone. I'll work with Terri after the call and we'll get that organized and it will be included in your follow-up email with the link to the recording. And then our final question, because I know we're all busy, fantastic and very helpful discussion. Out of curiosity, is there a reason for MRI protocols and gestational age of the infant at the time of MRI request to be different in different countries? It seems the US is more apt to get an MRI early on, and where I am located, if a kiddo is 32 weeks or older at birth, they, quote, don't qualify for an MRI. This seems to open the door for kiddos to slip through the cracks in terms of catching an injury.
Yeah, that's interesting. So we'll touch on more of this, I think, in part 2 when we cover the preterm infant, and we'll talk a lot, and I hope people will join and really learn about what MR may have to offer in the preterm brain. I think there are variations both by regions and by countries. And what I would say, and I wish I could say it differently, but what I would say is honestly, it's about who's championing it. If you've got a champion in your center who can tell a story of why this is important, then what I find is that once you open the door and start doing the imaging on these kids, and the 30 to 32 weekers, or even the 28, I would say the 28 to 32 weekers are probably the most ignored species in our units at the moment, because we're all focused on 22 and 23 weekers now. And we kind of have forgotten about those 28 to 32 weekers who honestly aren't doing that well and who have a lot of preponderance for white matter injury around birth. I admitted a 30-weeker last night, and they had a base deficit of -14. That had some fetal heart abnormalities and had a stat section. No one calls them HIE, by the way. And no one thinks, oh my gosh, that baby could have taken a cerebral insult to their cortex. We should do an MRI on them at some point. We just talk about them differently. We'll look with ultrasound for an IVH, maybe in the first week, but people aren't thinking about them. And I would encourage us to start to think more individually about every baby in front of us and what we think the risk profile is for every baby in front of us in terms of imaging. And the more you start to image, the more you're going to find. And that's going to help get resources to those babies who would not maybe otherwise have qualified for rehabilitation resources to help them recover from a brain injury and get the therapies they need.
I
So
think that
thank
was
you
an
for the
important
question.
point, Terri. Who is championing for the baby and for the needed imaging? So I think that was a great way to put that. I don't see any other question. Oh, wait, one more. As a physio, I have often found delays and emerging patterns of CP in a 32-weeker when I do an evaluation at 15 months, and the parent says, any medical records do not show any imaging done. It's just frustrating for the parent. Oh, I think everyone will feel your pain. Terri, would you like to speak to
Yeah,
it?
I think that, as I say, these 28 to 32 weekers or even 34 weekers, they're just an ignored species. And I wish we had better ways, as I say, of risk defining. I do think even a term ultrasound is better than nothing. And if you find anything on that term ultrasound, I had a 32-weeker not long ago, a twin, who the Neo at least remembered to do a term equivalent ultrasound, and that picked up cystic PVL completely unexpectedly. And when we went back, this baby had been ventilated very briefly and given surfactant and had quite a prolonged period of low CO2, unfortunately. And probably that was in a high-risk infant enough to provoke the PVL. But if that infant hadn't have even had an ultrasound, the early ultrasound didn't show anything, of course, in the first week of life. It was this late ultrasound. But I think you've got to have as I say, you've got to have systems in place. I would love to have every unit having therapists who had routine, standard evaluative tools prior to discharge as well. And if any abnormality is picked up, how many of these babies have significant feeding difficulties? How many of those kids get imaged? A lot of them don't.
Very few.
And I think that could be very informative to help us understand and explain to the parents. And if you image them when they're in the unit, or before they go home, you can do it without sedation. You can do it by feed and wrap. You can't do that very easily at any other time in life. It's much, much harder because they need to have anesthesia, and who wants to do that to a baby at an older age?
If you go all the way back to the beginning of your presentation and talking about those preparatory steps of getting your process really established and getting your team really lined up and working collaboratively, and having, from the conversation with neuroradiology and the conversation with radiology administration about access. And if you make all of those preparatory actions fruitful, if you're able to really work on those, then you start freeing up greater access potentially. So, to your question, a baby with prolonged feeding challenges, the likelihood of them being imaged solely because of that activity is very low. But if you have a process that's well established and the wheels are greased really nicely, then you increase the likelihood of being able to image those. And we start to learn even more about the nuanced association between some things that we may not think of and findings that might appear on imaging.
That's right.
That's the ideal state. That's where we hope we're all headed.
And we'll talk more about that with the preterm infant in part 2.
Terrific. All right. Thank you all for hanging with us. I don't see any other questions. Again, Terri, thank you so much for your time in putting this together and presenting this for us and spending time with our audience answering questions. I know we're all looking forward to part 2. Let's start talking about those tiny babies and not just the 22 weekers. Let's talk about those 28 to 32 weekers. Thank you all for your time. Enjoy the rest of your day, your evening, your morning. We will hopefully see you next month for part 2, and watch your email for the slides and the link to the recording. Thank you so much.